Testing, testing. Brooke, can you hear me?
Yes.
Good. Feeling better?
Yes.
Cool. Well, you're in good company because a few other people are sick too. So okay. She might have. But she's apparently she drove somewhere or something and she's stuck. So she's gonna do it on her phone. All right. Ladies and one gentleman who's here. I have a quiz and there's no name on it. And I can't tell whose it is. So if you didn't get a quiz back and you're pretty sure this is yours, you took the quiz, come up and have a look at it and claim it. It's whoever took it did pretty well, but I didn't give you a score because I have no idea whose it is. If you need to take the quiz, I photocopied some more and they're probably in those handouts back there. So I'll go collect those at some time. So if you could please get your handouts out. We talked about treating high cholesterol. And we also talked about treating, will you show it to the camera? Sure. So we talked about how to get your cholesterol levels down, talked about what healthy cholesterol levels are. And we also took a look at triglycerides, drugs that are used to get triglycerides down. And then we looked at the pathophysiology of atherosclerosis, why it's important to control blood lipids, why it's also to control. It's mine if I wrote the lab values. You wrote the lab values. So, you know, Clara, I was wondering if that was yours. So this apparently is Clara's. So, okay, I'll get that into, I'll get it into the scores. No, Clara, it's okay. No need to say sorry. It happens. I'll try and get that into the scores as soon as I can. Okay, just obviously not right now. Now, as we were saying, we looked at drugs like statins, and we looked at niacin and fibrates and the bile acid resins. We also looked at some monoclonal antibodies for people with familial hypercholesterolemia. I hope you were able to download the handout. And on the back of that handout, there is a new drug, this inclisiran, that goes by the trade name Leqvio, that is actually a small interfering RNA that's attached to a sugar, and then that sugar takes it into the cell, which is frankly quite ingenious, and then it interferes with the PCSK9 messenger RNA. And so this is some of the newer technology you're saying for people with familial hypercholesterolemia. Today, I would like to look at the consequences of coronary artery disease. So this is angina pectoris, and then also treating people with heart attacks, treating people with ST elevated myocardial infarctions and non-ST elevated myocardial infarctions. This will also bring us into a discussion of anticoagulants, since anticoagulants are used in this patient population as well. So first of all, were there any questions last time with my very fast discussion about lipids, statins, anything like that, anything that was unclear from last week that you want revisited? No? Oh, question? Go ahead. Oh, you said no. Okay, never mind. All right, then we'll start here. Come on, you. Okay, there we go. We look at the blood supply to the heart. We see that the blood supply to the heart is relatively humble. You have a structure that's more or less the size of your fist, and yet the vessels that feed the main chambers are relatively sparse. So from the coronary sinus that is at the base of the aorta, you have two vessels that come out and then branch, and you have the right coronary artery and the left coronary artery. Let's take the left one first. So the left is going to have a major branch right up towards the top of the, towards the middle of the atrium there. One of those branches will head down towards the apex of the heart. That's the left anterior descending coronary artery. This is probably the one that, well, no, it's not probably, it is. This is the coronary artery that gets plugged the most. So about 60% of your myocardial infarctions result from atherosclerotic occlusion of the left coronary artery. If you have a blockage really high on the left descending, left anterior descending coronary artery, people in the field call that a widowmaker. You can guess why it's called a widowmaker, because your chances for survival are not so hot. There's a branch of the left coronary artery that swings around the heart in the intraventricular sulcus. That is called the circumflex artery. The circumflex artery, that is going to swing around, and then it will descend downward on the back, and you'll have the posterior interventricular artery, sometimes called the posterior descending artery. It's called both. The next slide I have, it'll be called the posterior interventricular because it goes right down the septum and it feeds the back part of the septum. There's a branch, as you can see here, that's called the diagonal, the left anterior diagonal. It's a branch of the LAD. That back artery, sometimes it's a creation of the left coronary artery, sometimes it's a creation of the right coronary artery. Depends if you're left or right dominant. So that's going to vary from person to person. Also, it means that the effects of heart attacks are going to differ in their severity from person to person, depending upon the configuration of coronary arteries you happen to have. Sydney, I saw that. You need chocolate. Chocolate. Get that awakeness there. Take a look at the right side. You have really one artery. That's the right coronary artery. Then there's a branch here. That's called the right marginal artery. And then there is another branch typically that will go to the back and it will stop around the back of the right atrium. In some people, it will go on to form the posterior descending artery, posterior interventricular. So here's an example of those two differences we were talking about. So in most people, the circumflex, as you can see, swings around and it forms the posterior descending, otherwise known as the posterior interventricular. Some people, however, have the so-called right dominant type of circulation, where you have your left ventricular branch here, posterior ventricular branch, which is this over here, and then it stops. And the posterior interventricular comes from the right side. So that's a feature to remember. Not everybody who has a heart attack will experience the same amount of damage in the heart. If you have a blockage of that circumflex artery, if you're left dominant, it's also going to hit the back of the ventricle, whereas you're right dominant, it won't. That is significant because that particular branch is going to feed the atrioventricular node.
So how would you be able to tell if somebody's right or left down?
Echo. Then a good echo tech will be able to tell you. That's actually a good question. Lots of times in cath labs, there's an echo wand with an echo machine right in the lab, and you can just put the wand on and just get a quick echocardiogram really easily. The echoes now, echocardiograms, I mean, they used to take up half the room. Now they fit on a table. They're tiny. And the wands, it used to be, you had to have this whole thing. Now it's just this wand that's this big and you just put it over the chest and a good tech can read the heart really easily. So if a coronary artery becomes over 75 to 80% blocked, you're now going to have a mismatch between the oxygen demand of the myocardium and the oxygen delivery to the myocardium. Typically, here's the way the heart tends to work. The heart works by something called autoregulation. The more you demand from the heart, the more you vasodilate those coronary arteries. So the greater your demand. So when our colleagues over here get on the volleyball pitch, it's not called a pitch, sorry, that's soccer court. Get on the volleyball court and they start hopping and jumping around and swinging their arms like they're chopping wood or something. Their heart rates are going to go up. Their coronary arteries are going to dilate. Therefore, even though they're demanding more from their heart, their oxygen delivery to the heart compensates. In someone with severe atherosclerotic stenosis of coronary arteries, you cannot compensate for increased demand on the myocardium. Therefore, the myocardium will experience ischemia. Jessica, what's ischemia mean? Caitlin, what's ischemia mean? Lack of oxygen. Good, very good. Lack of oxygen. And it could mean no oxygen, but it can also mean inadequate oxygen. It doesn't have to mean no oxygen. Ischemia, think of it more in grades. But what does the tissue need? Is it getting adequate supply? If it's not, then the tissue is becoming ischemic. Might not be cut off, but it's still going to become ischemic. Now, skeletal muscle. Skeletal muscle becomes ischemic. It switches to anaerobic metabolism, starts to make lactate. Cardiac muscle is not like that. If cardiac muscle becomes ischemic, it throws a temper tantrum. And it will start to, at least in 20 minutes, it will start to die. So this is going to cause crushing, pinching chest pain substernally. It may radiate to the jaw and to the inside of the left arm. This is not a pain, oh, I did too many declines in the gym. Oh, I got a cramp. No, this is you have to stop and you clutch your chest. This hurts. This really, really hurts. This is called angina pectoris. Angina pectoris. This is relieved by resting. When you rest, it goes away. Or if you take organic nitrates like nitroglycerin, it goes away. Can I get a question?
So is this mainly when you're doing like activity?
Yes. Yes, and we'll see there's different types of angina. The more classic one, the one you see most often, is predicted based on activity level. All right, you with me so far? So we read that little clinical vignette last time. Let's just read it again. Anish, a 54-year-old man with a known history of hypertension, hyperlipidemia, and a 25-pack a year smoking habit, complains of shortness of breath, squeezing retrosternal chest pain that radiates to his neck, jaw, and left arm. He's been having these episodes, but they come only after riding his bicycle for at least 20 minutes, and they're relieved once he rests. That is classic angina pectoris. Classic. So when I pass this out, if you still have that, you might want to write that is angina pectoris. Now notice that after the pain subsides, his EKG is normal. Also, his blood work is normal. The myocardium does not die. Oxygen is restored, adequate oxygen rather, is restored to the myocardium in time before it dies. So this will not produce long-term damage to the heart, but it will limit activity. And this is a result of atherosclerosis of the coronary arteries. There's also, yes.
I don't know if it's on here, but like, is there a way that people can get facts if they don't, like if they, so if somebody's having this?
Stenting. Stenting, yeah. Stenting can open it up and help with that, yeah, definitely. Some people can eat a large meal and get angina, that's called holiday heart. Stress can cause it. Smoking can cause it because smoking increases the oxygen needs of the heart. Not all types of angina are due to atherosclerosis. The one I'm introducing to you right now is. We're on the same page. Good. I'm going to go on. This is different than a heart attack. With a heart attack, you have complete occlusion of the vessel. You do not get relief of pain with rest. The pain also tends to be more intense and more severe. It's also not relieved with organic nitrates like nitroglycerin. So there are two types of heart attacks, myocardial infarctions. The first one, let's look to your left. We have a non-ST elevated myocardial infarction, or an N-STEMI. N-STEMI. Remember that the coronary arteries lie on the epicardium of the heart. They send their collateral circulation into the myocardium. So if that vessel is blocked, death begins at the epicardium and it spreads inwardly. If your ischemia does not go all the way through the wall of the heart, that will cause a non-ST elevated myocardial infarction. You can see that you get depression of the ST segment in the EKG with a N-STEMI. You might also get inversion of the T wave, depending on the lead you're looking at. If you look at your right-hand side, if the ischemia and the cell death go all the way through the wall of the heart, that is called an ST elevated myocardial infarction, or a STEMI. This is also called a mural myocardial infarction. And again, remember, MI does not mean Michigan. It means myocardial infarction, heart attack. In this case, as you can see, the EKG shows elevation of the ST segment. Where in the leads tell you where in the heart you have the cell death. So it can tell you which of the vessels is actually blocked. Now, when it comes to blood work and heart attacks, there are some molecules that can tell you if someone has had a heart attack. The first of these is troponin. Troponin levels in the blood, because heart cells are dying, so they are essentially lysing and they're throwing their components out into the blood. So within 2 to 4 hours after the heart attack, troponin levels will start to become elevated. They'll peak at about 48 hours and they'll stay elevated for 7 to 10 days. So troponin is an excellent long-term marker. Troponin can tell you if someone has had cardiac cell death. The other marker is creatine kinase. There are different isozymes of creatine kinase. When it comes to the heart, you're going to see a combination of the M and the B isozymes. So just remember your professor's initials, and that'll help you remember this. This one also elevates 2 to 4 hours post-MI. This peaks at 24 hours after the heart attack. By 48 hours, it's back to normal. So this one is good short term. So once again, our little vignette that we passed out last time. Erica is a 66-year-old woman with a history of diabetes mellitus who complains of sudden onset shortness of breath, fatigue and dizziness, but no chest pain. Please make this note. It's very often the case that people with diabetes, particularly poorly controlled diabetes, do not have chest pain when they have a heart attack. An ECG reveals ST segment depression, and troponin levels are elevated. What do you think she has? Guys, just look at the slide. ST segment depression and high troponin levels. So troponin levels, so she's having a heart attack. Now, which one? Does she show ST elevation or ST depression? ST depression. So she's having an STEMI. Creatine kinase is not necessarily specific for the heart. Muscle damage can give you this too. That can actually fool you under certain conditions. Nevertheless, when associated with a myocardial infarction, the signs and symptoms of a myocardial infarction, you will tend to be able to say that this is probably due to damage to the heart. The most common cause of obstruction of coronary arteries usually results from atherosclerosis. Coronary artery disease is responsible for half of all the deaths in the United States. Pretty sobering fact, isn't it? So let's discuss angina. Angina, very simply, is a discomfort in the chest that's caused by myocardial ischemia and is associated with disturbance of myocardial function without myocardial necrosis. The discomfort of the chest caused by myocardial ischemia, associated with a disturbance in myocardial function, but without myocardial necrosis. And it's a result of an imbalance between myocardial oxygen supply and myocardial oxygen delivery. With an MI, the pain is relentless. It's not relieved by rest. The area of the heart that has died is also electrically dead, and it's unable to conduct electrical impulses. And as we'll see, one of the big risks after a heart attack is arrhythmias. So the vessels on the surface of the heart, these are the conductance vessels that are responsible for the coronary circulation. Again, these are on the epicardium. They send their resistance vessels into the myocardium. So you have this picture here where you have the vessel on the epicardial surface. It sends its collaterals into the myocardium. Those collaterals branch extensively, feeding the myocardium and the endocardial surface, and then being drained by veins. And in that picture I showed you, you might remember the veins of the heart closely parallel the arteries. They're pretty much right next to each other. Now, this collateral circulation is greater in an older person than in a younger person. That's one of the few blessings of growing older, besides all the wisdom you're supposed to acquire. When I acquire it, I'll let you know. This is the reason why a heart attack in a younger person is usually fatal relative to a heart attack in an older person. Because younger people have not lived long enough to have acquired that much collateral circulation. So your increased myocardial oxygen requirement must, and must is capitalized. You might want to underline that and put a star by it or highlight it with your highlighter or something like that. Must be met by increased coronary blood flow. When you exercise vigorously, coronary artery blood flow can increase 5-fold above resting. In patients with angina due to coronary artery disease, there's very little reserve to provide increased blood flow. Hence the ischemia and the chest pain. And again, as we said, this increased flow is due to this autoregulation. What sort of things determine myocardial oxygen demand? There's 3 main components. And this is a little review of A&P, but little review won't hurt you. So number 1, heart rate. Faster it pumps, more oxygen it needs. That I hope has an intuitive sensibility to you. When you're exercising, what happens to venous return? What do the skeletal muscle pumps? Remember your veins in your lower extremities particularly are deep. So as your muscles contract, say you're running, you get the skeletal muscles, they're doing this to the blood in the veins. What happens to the venous return when exercise? Goes up, can go up substantially. Because your venous return is increasing, you're stretching the walls of the ventricles more. Okay, from A&P last year, Frank Starling law. Frank Starling law says, okay, so I just saw it not by Rebecca. She remembered the term. She's not sure she remembers what it says. But the heart muscle is like a rubber band. The more you stretch it, the more powerful the recoil. So if you take a rubber band and do that, it won't hurt you. Stretch back like that, it'll hurt you. Stretch back like that, like, oh, it's going to really hurt you. The more you stretch it, the more recoil. Think Frank Starling, think rubber band, rubber band, rubber band. So the more you stretch it, the greater the force of contraction. All of those things, the rate, the stretch, the recoil, the force of contraction, influence myocardial oxygen demand. The more you stretch, the more oxygen you need. The harder you contract, the more oxygen you need. The faster you beat, the more oxygen you need. Delivery is determined by vessel diameter. You vasodilate. One of the biggest vasodilators in your body, as your muscle cells use up ATP, they will hydrolyze that ADP and they'll make adenosine. And adenosine is a potent coronary artery vasodilator. Potent. And that gets used in the ICU as well for people who need to have their coronary arteries dilated. Also, the length of the lesion. The length of the lesion will diminish. The longer the lesion, the bigger the lesion, the lower the amount of oxygen you can deliver to the myocardium. Also, some people have an angina that's born of spasm of the coronary arteries. And the degree of spasm, of course, will diminish oxygen delivery as well. So there are three main types of angina. Oh, by the way, this might help. The word angina comes from a Latin word that means to squeeze, hence the squeezing pain you get in your chest. Classical angina, either unstable, sometimes called atypical angina, vasospastic angina, and then myocardial infarction. Classical angina, sometimes called stable angina, unstable angina, vasospastic angina, and myocardial infarction. Classical angina is precipitated by physical activity or stress and is predictable. It is predictable. Put predictable in big, bold, capital letters. That's the biggest hallmark of classical angina. It's predictable. So you get either the older chap, or I suppose maybe the middle-aged, overweight, out of shape chap, who goes out to shovel the driveway. That's an example of classic angina. There you go, exerting. Ooh, I gotta rest. Ooh, that hurts. The pain usually begins gradually. It reaches maximum intensity over minutes before it dissipates. And it is usually the result, that dissipation is a result of ceasing whatever activity precipitated. The pain is described as heavy, crushing, or squeezing. Localized usually retrosternally, may radiate to the neck or the left arm, but you have to stop activity in order to have the pain go away. It's caused by atherosclerosis. It occurs when you have obstruction of the coronary arteries that exceeds 75 to 80%. Sydney?
What would happen if you
you'd kill your myocardium. You'd start to have myocardial death. Which you'd have to have a pretty high pain tolerance to do that. Because the pain is going to get worse and worse and worse and worse. And most people have experienced angina. You'll get some people when you start in your career, they'll describe the pain. It's bad. It's bad. So your typical angina, atypical angina, also known as unstable angina, is of a very different nature. Now, is all chest pain cardiac in nature? No. I'll tell you a little story. So when I was at University of Pennsylvania, the medical school there, they have this program where the upper class medical students tutor the lower class medical students. So a third year medical student who was frankly way too perky for her own good, looked like she'd had several cups of coffee, was trying to do a tutorial with these first year medical students. And she was trying to get them to think of causes of non-cardiac chest pain. And I was coming in, I was filling up my water bottle because they were in the kitchen on the floor where we were. So I went in, I filled up my water bottle, and I was thinking, I just earshot, oh, epiphyds, oh, heart attacks, oh, okay. When are most heart attacks? I'm thinking, myself morning. Somebody finally goes, yeah, your cortisol levels are high. Cardiac pain, non-cardiac pain. And then finally, I'm getting ready to leave. She looks at me and she says, non-cardiac chest pain, what can cause it? I'm like, zoster infection? She said, yes. Thank you. And yeah, so a zoster infection can affect the mediastinal lymph nodes. That can cause pretty severe chest pain. That's not cardiac in nature. Good example, for example, let's say you get a 72-year-old lady comes into the office, she's got this chest pain, it's kept her up at night, couldn't sleep. Resting doesn't help. It happened at rest. You hook her up to the EKG, EKG is normal. That could be an example of a varicella zoster infection. That might be a sequela of shingles, a shingles incident or something like that, or some other incident. So, yeah. Yeah, acid reflux can cause pain that can seem a lot like heart attack. Some people will get it high up in this area here, or they get it here and then it kind of, the pain kind of shoots up like that. That shooting pain can seem a lot like a heart attack. So severe acid reflux can certainly seem like a heart attack. With acid reflux, usually their medical history will show that they have a history of acid reflux. Also, they may be on proton pump inhibitors as well, or if they're not, they should be on. And then if you hook them up to their EKG, EKG is going to be normal. Usually, if you come in with chest pain, you get hooked to the EKG and you get offered nitrates. Word of the wise about nitrates: you give someone nitrates, they're going to have the queen mother of all headaches, because that stuff vasodilates both veins and arteries. And one of the ones that dilates really well, the ones in your head, you're going to get that. Oh, and if you're prone to migraines, it's going to make those migraines seem 50 times worse. So just keep that in mind. When you're giving people sublingual nitrates, warn them. This is going to give you a headache. I'm sorry, it's going to.
Is there an alternative to that?
The test to see if it goes away is nitrates. So if you want to just do the EKG and the EKG is normal, then you may not need the nitrates. But usually protocol says you try nitrates. But if someone has a migraine, and this is where you, the nurse, can be the advocate for the patient and say, this person gets bad migraines I really don't want to do this to them. Can we forego the nitrates unless it's last resort? Let's just do the EKG and, oh, look, the EKG is normal. Because to do that to a person with migraines, that's unusual punishment. What'd you say? Yeah, because it will, trust me. Trust me. You'll have a headache. So unstable angina seems to result from atherosclerotic plaques that pop. So you start to get the clots, but the clots don't occlude the vessel completely. So then that gets dealt with. You get some healing of it, then it pops again. So these just have a tendency to pop. So these tend to have a tendency to lead to an MI. They're often not responsive to nitroglycerin. They may persist for longer than 30 minutes. The pain can be more intense than the pain you get with stable angina, as you see here. It's a progression of atherosclerosis, the aggregation of platelets, and then because of the damage to the wall of the vessel, you'll start to get vasospasm. That increases the risk of angina and the pain. Vasospastic angina tends to run in families. It also will tend to occur at rest. Pain is cyclical, usually the same time of day, usually at midnight or early in the morning. The pain is usually less intense than with regular angina pectoris. Patients with vasospastic angina may have a history of Raynaud syndrome or migraine headaches. The etiology is not understood at all, just not known. So with this one, a good medical history really is your best friend. So when you guys take fundamentals, listen carefully at how to do a good history. Good history is worth its weight in medical gold. With a myocardial infarction, the pain is more intense. It lasts longer than angina pectoris. The pain may radiate down the inner side of the left arm, up to the jaw, up the neck to the jaw, or do both. In older women, it's not uncommon for the pain to be between the shoulder blades. The pain is accompanied by activation of the sympathetic nervous system. So you get sweating, nausea, vomiting, weakness, and very often anxiety. The pain will not subside with sublingual nitroglycerin. Most heart attacks occur in the morning because in the morning you get that cortisol spike in the morning. That's what tends to cause most of the heart attacks. So stable angina is classified according to the New York Heart Association classification scheme as class 1, 2, 3, or 4. With class 1, you only get pain after exertion, respectable physical exertion. You don't get pain with ordinary physical activity. You don't get it when walking. You don't get it when climbing stairs. You get it with strenuous, rapid, or prolonged exertion at work or recreation. That's class 1. Class 1. So with class 1, you don't have any limitation of everyday activities. Class 2, You get pain with walking or climbing stairs rapidly. You may get pain after meals. Extremes of hot or cold may cause anginal pain. Emotional stress may cause it too. So now you get some slight limitation of ordinary activity. You have to slow down a bit. With class 3, now you get more marked limitation on physical activity. Walking 1 or 2 stairs, climbing a flight of stairs at a normal pace will cause angina pain. Walking 1 or 2 blocks on level ground will cause angina pain. And then class 4, you have pain at rest. This is a perfect time to take a break because now we'll go into how you treat these. So let's take 5, come back, and then we'll resume. Everyone's so quiet tonight. Is it the cold weather? I don't know, dude. It's pretty cold out there. Ridiculous. McKenna, I tried to redo my Dropbox. I think what happened is that with the new Blackboard 9.1, I think the way to do Dropboxes is different than the way I do Blackboards. I think. So I'm going to redo the Dropbox and we'll try it again.
Okay.
Okay.
Talking about for the interview?
Yeah,
From this interview?
yeah, you'll be able to put it in the Dropbox. So.
I've seen a lot of Tupac pills too. He really just issued. Oh, just one? Yeah. Yeah, he just. Oh my goodness. There was one I seen that was like. I didn't watch. I didn't watch Fresh Prince. Okay, and then this one. Oh, I.
No one can see it, then if I take it out and put it back in, it'll probably start working. All right, that's 5 minutes.
At first I was like, okay, I get it.
All right, folks, it's been 5 minutes. Let's go ahead and get back in the saddle. So to treat angina, one of your first arrows in your quiver, of course, are lifestyle and diet modifications. Your patient needs to exercise moderately, lightly or moderately. I will bring up once again the old British bromide of get a dog, whatever it takes essentially to get moving, and then diet modifications as well. The diet needs to be more plant-based, and they also need to reduce saturated fats in particular in the diet, and they need to reduce the glucose in the diet as well. We will talk a little bit about antiplatelet drugs. Now we'll talk more about them when we get to anticoagulants, which is actually next. Lipid-lowering agents are going to be very important. They were able to get to this point because their serum lipid levels are too high. So they need to be on something to lower their lipid levels, and they need to make sure that their lipid levels, their LDL in particular, is in a healthy range. That is really key. Beta blocking agents do a very good job of preventing angina pain. So if you look at your handout on angina pectoris, it will show you essentially that beta blockers essentially are, because beta blockers reduce the oxygen demand of the myocardium, it can prevent anginal attacks. Now, if someone cannot tolerate a beta blocker, then you can use a calcium channel blocker, in particular, verapamil or diltiazem are the two drugs of choice in that case. Both will decrease cardiac rate and decrease the oxygen demand of the myocardium. ACE inhibitors are also very good drugs to lower blood pressure, to cause vasodilation, and to decrease afterload. If you decrease afterload on the heart, you're going to decrease the myocardial oxygen demand as well. Now, those are all long-term treatments to essentially ensure that you are able to prevent myocardial infarction and death. That's the goal of treatment. The short-term treatment will be your nitrates. Nitrates will relieve pain. They don't necessarily affect prognosis, but they do relieve pain, and they're very good at that. Let us first describe oral antiplatelet agents. So these are going to prevent platelets from sticking together. We'll see when we study anticoagulants that drugs that inhibit the coagulation cascade tend to be used for veins, and antiplatelet drugs tend to be used for arteries. Since these are coronary arteries, you're going to use antiplatelet drugs. Now, the drug that's usually used in this case is going to be both aspirin and clopidogrel. And clopidogrel also is generic nowadays, but it was known by the trade name Plavix. Plavix. I'm gonna, let's see, how much money do I have? I'm gonna lay some dollars that you guys have heard of Plavix. There have been lots of commercials of Plavix. It is a very widely used drug. So these drugs prevent platelets from adhering together. So they prevent thrombosis in the arteries, and they will prevent myocardial infarctions. So these will prevent stroke, they'll prevent myocardial infarction, they'll prevent shunt clotting in people undergoing hemodialysis. And they are used extensively after CABG, otherwise known as coronary artery bypass graft surgery, CABG. You'll never look at St. Patrick's Day cabbage and corned beef quite the same again, will you? Please. Yes. All anticoagulants have as their side effect increased bruising, increased bleeding. It's a trade-off. Trade-off well worth it. But as the nurse, that means you're going to have to check gums. You're going to have to check for sort of coffee ground vomit, black tarry stools, ecchymosis, bruising, these sorts of things, bleeding in the joints. These are all things you're going to have to check the patient to make sure that they have good range of motion, no pain, no bleeding gums. You ask them if they've been to the dentist lately. Use a soft toothbrush, blah, 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 so on and so forth. There's a whole rigmarole you have to go through when people are on anticoagulants, antiplatelet drugs because of the increased risk of bleeding. Antiplatelets tend to be better tolerated than anticoagulants. Beta blockers. These are usually given orally. Well, they're almost always given orally, let's put it that way. Decrease heart rate. They decrease myocardial oxygen demand. So they decrease the heart rate, decrease contractility. They will increase coronary blood flow because they will tend to extend diastole when blood flows into the coronary arteries. Recommendation by the American Heart Association is that you use a cardioselective beta blocker. We went over the side effects of beta blockers already. Please look that up if you are unsure about it. Cardiac nitrates. There are two main types of cardiac nitrates, fast-acting and slower acting. For angina, you're virtually always going to use a fast-acting. That means nitroglycerin. Nitroglycerin. Nitroglycerin degrades into nitric oxide. Nitric oxide activates guanylyl cyclase, which increases cyclic GMP levels inside smooth muscle cells. Cyclic GMP is a potent vasodilator. This drug will vasodilate both veins and arteries. So it decreases afterload and preload. It's used for all types of anginas and all types of ischemic heart disease. You can use them prophylactically as well. Let's say, I don't know. Let's say Sydney marries the love of her life and grandpa wants to get out and dance with the bride, but grandpa's got a bad ticker. If he goes out and he tries to shake his booty with Sydney, he's going to have chest pain. He can pop a nitroglycerin before the song starts and say, "Dear granddaughter, may I have this dance?" And then he won't have chest pain when he goes out and gets on the dance floor with Sydney. They can be taken prophylactically. And since Sydney will be a practicing nurse, she can advise him accordingly. So because they vasodilate veins, arteries, they reduce afterload and preload. There are two other products that are organic nitrates. There's isosorbide dinitrate, which doesn't get a lot of use. The more commonly used isosorbide mononitrate. The isosorbide products are long-acting nitrates. The most common formulation of nitroglycerin is sublingual. Sublingual. You pop a tablet under your tongue. Under your tongue, the tissue is very heavily vascularized. The tablet breaks down and the nitroglycerin is absorbed very quickly into your bloodstream. Nitroglycerin, of course, is not very stable, so it degrades to nitric oxide and it causes vasodilation. Nitric oxide is a gas, diffuses very quickly, has a short half-life, but it diffuses very quickly and acts quite quickly. So your sublingual nitroglycerin usually will start working within tops 5 minutes, usually within 2 to 3 minutes. Will last usually about 15 minutes. If the pain still lasts, you can try again, usually. "10 to 20 minutes later. If you use nitrates a lot, you will suffer from so-called nitrate tolerance. Now, this type of tolerance is due to something called tachyphylaxis. Tachyphylaxis is a type of tolerance that results from the exhaustion of a required cofactor for the drug to work. The cofactor in this case is GTP. So because you're making all this cyclic GMP, you burn up all the GTP in the cell. So now you have the nitrates that don't work anymore. So if you overuse nitrates, they will stop working. That is something to keep in mind with nitrates. Your long-term nitrates, your isosorbides are usually tablets. There are, however, versions of nitroglycerin that are long-term. So there's a nitroglycerin patch you can wear. The patch should be applied to a hairless part of the body. You want to have the patch on for about 10 hours and you want it off about 12 hours. Once again, what do we say about discarding patches? Flush them. Take them, fold them in half, flush them. Don't say, ooh, what's this? Nope. There's vehicle on there to get through your skin. If you say, ooh, this looks gooey, that feels kind of cool. Gee, I wonder if it's good for my face. Don't do that. Don't do that. There's also an ointment. The ointment is cheaper than the patch. The ointment comes with an applicator. Do not use your fingers for the ointment. Also alternate where you put the ointment, just as alternate where you put the patch. Use the applicator and then make sure that you wash it off and that you wash your clothes. You wear those same clothes and there's nitrate ointment on there, you might get a dose of nitrate you weren't counting on. So that is something to keep in mind with the ointment. The ointment may also stain your clothes. That's a downside of the ointment. Side effects of nitrates are headache, dizziness. Dizziness, as people become more tolerant of it, tends to go away. Hypotension is a genuine possibility, especially if you're already on a beta blocker. And then, of course, nitrate tolerance. Also, you never use nitrates with phosphodiesterase inhibitors like sildenafil, tadalafil, vardenafil, like Viagra, Levitra, Cialis, drugs like that. You put those two drugs together, your blood pressure is going to tank. Don't use those together. Talked already about tolerance, so I don't think I need to spend a special amount of time on that. Yeah. So a sublingual, patch, paste, and then PO, oral drugs. So the patches are used prophylactically. You'll learn this in fundamentals, but when you put on a patch, you always date a patch and you put the time on the patch because you may not remember when you put it on. You always date it and put the time, and then when you put the patch on, you should wear gloves when you're putting patches on. Doff your gloves, and then that way you can look in the mirror and say, oh, I put that on at 10:30, or I put that on at 6:45, or I put it on. Don't have the 14 on, 10 to 12 off, so on and so forth. Don't sleep with it on. Talked about the ointment already. The ointment is really cheap. Really, really cheap, really inexpensive. The sublingual nitroglycerin, you have to make sure you store it in a cool, dry, dark area. So it will come in a dark bottle. Light will tend to break it down, so will heat. A lot of people will take their nitrate tablets, put them in their glove box during the summer. Bad idea. Heat will cause them to be destroyed. Also, cotton, the cellulose will react with the nitroglycerin and will break it down. No cotton in the bottle. When you get a prescription of nitroglycerin, you also have to make sure you don't mix new pills with old pills. So here's some of the products. Here's kind of the pharmacokinetics of these. So the isosorbide dinitrate, you can see, lasts a lot longer than the nitroglycerin. Oral nitroglycerin, I looked it up on Hippocrates today. They stopped making it. It's not marketed anymore. So you used to be able to get oral nitroglycerin. Apparently, some people were using the oral nitroglycerin to make bombs. So I think, yeah, the FBI said, can we please not market oral nitroglycerin? People are stupid. And then the ointment and the patches and whatever. Oral mono isosorbide mononitrate, that can be very long lasting in some cases. It'll take longer, usually for those who start working. The sublingual, you can see, starts very quickly. You could take one every 5 minutes, 3 times. Wait after you've taken the third one for sure. You can use nitrates with beta blockers. Those two play quite well. And if you can't tolerate a beta blocker, you can use a calcium channel blocker. But use a non-DHP in this case. Do not combine calcium channel blockers with beta blockers. That's a good recipe for a heart attack. Scratch. Don't combine non-DHP beta blockers with beta blockers. Some cardiologists will do that if you adjust the dosage. Many cardiologists will say, just don't go there. So these drugs are for prevention. So prophylaxis. So you can use diltiazem or verapamil. If you use the DHPs, just remember that the immediate acting DHPs will tend to cause reflex tachycardia. That will increase your angina attacks. So if you use the DHPs, make sure you use the extended release formulations. And we talked about side effects of the calcium channel blockers. I don't need to revisit that again. ACE inhibitors, there have been several studies. One of the big ones was the so-called HOPE study. That was a post-marketing study. And this showed that the one that was tested was ramipril, but virtually all the others that have been tested in smaller studies work just as well. They decrease morbidity and mortality in patients with coronary artery disease. So they are used. And then, of course, statins. Lots of post-marketing data on statins says that they reduce the risk of death and hospitalization. There are a couple of new drugs, well, newer drugs. So there is ranolazine. Ranolazine is an inhibitor of the late sodium current. This will decrease your heart rate. So it blocks the late sodium current during ischemia. It will inhibit the calcium overload. That's usually a hallmark of ischemic myocardium. Because of this, it will tend to decrease the tension of the wall of the myocardium. Therefore, it decreases not just heart rate, but also oxygen demand. This is a drug that can be layered on other drugs like beta blockers or something like that. And it seems to have found a place essentially among the armamentaria of people who are treating people with angina. Ivabradine inhibits the so-called funny current in pacemaker cells and decreases the heart rate. Ranolazine is administered as an oral tablet. So is ivabradine. Ivabradine, the latest data that came out on it was not hugely favorable. So cardiologists are pulling back on ivabradine, whereas ranolazine as an augmenting agent has proven its worth. Ivabradine tends to affect vision. You tend to get these kind of halos around your vision. Ranolazine is usually well tolerated. You get dizziness, headache, constipation, nausea. That is a low frequency sort of event, but it's on the average pretty well tolerated. Ivabradine can cause pretty significant bradycardia. That's why I think many people are starting to pull back from it. So what are you to do? You are to essentially do the proper diagnostic testing. You're trying to see if the drugs are working. Are they following their lifestyle modifications? Acute treatment, how often are they taking the nitrates? How often do they need them? Are you taking your medicine? If you need a pill reminder, have you bought a pill reminder? Are you following the protocols that essentially were laid out for you last time we visited? This is just a little kind of mnemonic sort of thing. If you, nitrates versus beta blockers versus calcium channel blockers. If someone has vasospastic angina, beta blockers make vasospastic angina worse. Calcium channel blockers are the drugs of choice for people with vasospastic angina. Any questions about treating angina, angina pectoris in general, coronary artery disease, all that stuff like that there? No? Very good. We have a whole 10 minutes left. So let's just get started. Oh, crumbs, I didn't put it on the blast it. Blast it, blast it, blast it. Okay, well. Oh, wait, I don't think I did that right. Okay, so let's do, oops. Okay. Okay, so. Come on, you. All right. Gotta respect the Zoom. There. There we go. All right. So clotting the blood consists of two steps: making a platelet plug, reinforcing the platelet plug with fibrin. So platelets bud from megakaryocytes. They are capable of amoeboid movement. They don't last very long in your body, 5 to 9 days. You're calling somebody, they're going to have surgery. You tell them to get off their aspirin 9 days before surgery. 9 days before surgery, that's due to the fact that aspirin is going to inhibit their platelets. So just to remind you, your blood cells are made in the bone marrow. They are the result of a stem cell called a hematopoietic stem cell that divides, and then that cell will create the various different cells. And it's influenced by a variety of cytokines, growth factors that will determine whether it becomes a member of this lineage, that lineage, something like that. So red blood cells are made prodigiously by the bone marrow. They're stimulated by erythropoietin, which is made by the kidneys. When you have damage to a vessel, that damage is staunched by this process called hemostasis. It involves the formation of the platelet plug and then the formation of the fibrin cables. So inside a blood vessel, your endothelial cells, they make low-level nitric oxide and they make prostacyclin. That's what prostaglandin I2 is, prostacyclin. These two molecules, number one, keep platelets from being activated. Number two, they keep endothelial cells healthy. So these two small molecules essentially tell the bloodstream everything is Irie. Outside the blood vessel, you have collagen. There's no collagen inside the blood vessel, it's outside the vessel. Sticking to it, you have von Willebrand factor. Looks like VW. So remember the VW factor. When you breach the blood vessel, the blood is now exposed to collagen. Soluble von Willebrand factor in the blood is now going to stick to the collagen and it's going to polymerize. Platelets are going to stick to that von Willebrand factor and they're going to dump their granules. They'll change shape and dump their granules. Their granules are loaded with several things, but the three main important things for us is ADP, serotonin, and thromboxane A2. Serotonin and thromboxane A2 are going to take the vessel and vasoconstrict it. Which is easier to stop the blood flow from, a vessel this big or a vessel this big? A vessel that's this big. So you're going to undergo vasodilation. ADP is a rather potent platelet signaling molecule. And the other platelets coming by, you can see they're going to get activated. They will express now cell surface molecules that allow them to stick to their platelets. And they're going to stick. And they're going to form a platelet plug. That platelet plug is going to be reinforced by fibrin. And now you have staunched the flow of blood from that vessel. And here is a platelet plug, you can see here, with red blood cells essentially ensconced in the fibrin meshwork. This is then going to contract. It'll become more compact. The fibrin also provides a scaffolding for healing to begin as well. So clotting involves two pathways, the intrinsic and the extrinsic pathway. The extrinsic pathway is for those cases where you have damage to tissues. And the capillaries that feed those tissues have on their surfaces a small little glycoprotein called tissue factor. When that tissue gets damaged by trauma, shear forces, drugs, things like that, that gets rattled free. It now is soluble in the blood, and it is going to activate the extrinsic pathway. The intrinsic pathway is going to be activated if you damage a vessel. So this is damage within the vessel, and now the vessel is exposed to collagen. That's the intrinsic factor, intrinsic pathway. And I know after A&P, you prayed hard that you never have to see this again. Well, I'm sorry that prayer was not answered. Because to understand how anticoagulants work, you have to understand this pathway. So, don't like to spring it on you again, but hey, what has to be done has to be done. And there's two parts, extrinsic, intrinsic. The extrinsic is easy. Factor 7 combines with tissue factor, and it becomes an active protease now. And it cleaves factor 10 of the common pathway. The bummer is the intrinsic pathway, which has those 3 proteins involved before you activate factor 10. Now remember, we talked today about hemophilia in genetics. Factor 8 and factor 9 team up to activate factor 10. Those are the 2 proteins that are inactivated in cases of hemophilia. Factor 8 in the case of hemophilia A, factor 9 in the case of hemophilia B. So as you can see there, those 2 are not active, and the intrinsic pathway is hamstrung in those cases. All right, we are out of time. We'll revisit this on Wednesday. We'll look at anticoagulants. The thing about anticoagulants, the second you turn around, a new one's been made. So they keep coming. So again, my pledge to you has been to give you the most up-to-date information I can. So I will try to do that, give you the most up-to-date information I can. And then we'll talk about how you use these pups. Okay, those of you on Zoom, we are finished for the evening. Please get well, both of you, and I hope to see you soon. Good night.